So is it cancer or not cancer? Is that the debate today?
I think so. I mean, we've had a lot of debates about low-risk cancer.
Yeah, prostate cancer. But, it's like it says on the tin. People tell us, we've taken a biopsy, it's cancer. So it should be straightforward. I don't know why we even have to dedicate an entire podcast and acres of reading in journals recently to, is it cancer or is it not cancer?
It's good writing, though.
It is good writing, and it's a very good clinical discussion because of the whole context of this type of cancer. But that's what we're going to try and figure out today, folks, is Gleason 6, or as we call it nowadays, grade group 1 prostate cancer at all? Or maybe a different way of looking at it is, well, should we call it cancer, even if some people say, yes, actually, technically, this is cancer, but can we please actually drop the word cancer? And I think that's a fantastic topic to have on GUcast today, Renee, isn't it?
Absolutely, yeah.
So it's been triggered by some fantastic papers recently, especially a couple of great comments in European Urology, our big flagship journal, of course, running off the back of really a decade-long, I'm sure, conversation about whether this type of prostate cancer should actually be called prostate cancer. And the background, of course, is because there is still an issue with overtreatment of low-risk, low-grade prostate cancer. And although active surveillance is widely utilized in some countries, it's very variable in other countries. And therefore, there's still a cohort of men who are being overtreated because they've been diagnosed with this grade group 1 Gleason 6 prostate cancer. And what we want to do is invite on a couple of the great voices who've been involved in this discussion recently. And so it's a great pleasure to welcome on friends of the podcast, Matt Cooperberg from UCSF in California. Matt, welcome back to GUcast.
Hey, Matt.
Good to see you both. Good to be back.
And another friend of the podcast, Dr Eva Comperat, pathologist, a very well-regarded GU pathologist from Vienna. Eva, welcome back to GUcast.
Thank you. Welcome.
And I hope a few people are seeing this on YouTube, Eva, because we love that backdrop that you've got there. You've come prepared for battle.
She sure has. And new to the podcast, I don't think we've had Dr Scott Eggener, urologist from Chicago, on GUcast before. Scott, welcome.
Great to be here. Looking forward to it.
Great. Well, look, what a great trio to have on to discuss this topic.
Yeah, really good. And off the back of some fantastic papers, some rebuttals and some counterpoint debates, and I think we're going to have a great discussion today.
Yeah, and I think it's great to have Scott on in particular because he really has been a name that I always associate with pushing home this argument to say, can't we just stop doing it? And in the past couple of years, especially, Scott, you've written some great pieces, that big piece in the JCO earlier this year, and this piece in European Urology most recently with Matt and Andrew Vickers. And a patient of yours, Howard Wolinski, has also been involved, I think, in some of these publications. Yes. So perhaps we'll start with you to say, what is all this about, and why do you feel so passionately about it? What is the problem? What are you trying to address here? And before we get on to Eva's context, Eva's response to, why there's an issue with just dropping the term cancer.
Yeah, first of all, thanks for broaching the topic and having us on. The really brief answer to your question is I am absolutely convinced, based on loads of data, that public health would be better if we did not call it cancer. And for that reason, I and many others think it's an important conversation that we should have within the prostate cancer community. It's unassailable truth that grade group 1 is literally incapable of causing symptoms, spreading to other parts of the body. And I would argue there's not a man in history who's ever died from it or had severe local symptoms. And we should acknowledge that over the last decade or so, all the new tools that we have available, we're trying not to diagnose men with grade group 1. One of the great attributes of MRI is we don't see it and don't find it as much. All of our screening biomarkers, even some of the genomic tests. So we're pushing the argument out there to just have the conversation. It's a healthy, important conversation for all the prostate cancer community to have.
And do you think it's been met with some reciprocal acceptance or enthusiasm from, say, the urology community, Matt, to say that, okay, look, we recognize that we've gone quite a distance, led by people like yourself, promoting active surveillance. And as Scott says, the tools have improved. For example, in this country, widespread use of MRI has definitely led to less diagnosis of low-grade prostate cancer because we tend not to biopsy many of those men nowadays. But do you think that this may be the final thing that pushes the over-treatment issue away if we finally can actually stop calling this cancer in the first place? Because no one's going to do a radical prostatectomy or radiation or focal therapy, God forbid, for something that's not called cancer.
It could be. I think we have some hope that it is. And, we can recognize this conversation has actually been going on more than 10 years. 2009, Laura Esserman and Ian Thompson had a great editorial in JAMA talking about the parallels between prostate cancer and breast cancer in this regard, really making the point that a large proportion of both prostate and breast lesions have basically no clinical capacity for metastasis, and we should be calling them something else. 2012, there was a great Lancet review from the group in London from Ahmet and Mark Emerton, really emphasizing that there are no molecular hallmarks of cancer identifiable in grade group 3. And a lot more work has gone down in that line of research since. It does feel, though, this time that there's a little bit more momentum. This conversation has not sort of died with the publication. It's ongoing. And, I think there's some sense that we're on the right side of history here, and eventually there's going to be a change. Scott has some great data. You may want to talk about this, Scott, your survey of urology and pathology, but that gave me some hope that we might actually have an audience for the message this time around.
Sorry, Scott.
Just very brief. We have survey data from 1,300 people around the world from all different specialties. And we were surprised to see about half total were interested in either, considering a name change and didn't categorically refuse it. I think Eva's input is extraordinarily important because one of the two main factors of people who are most opposed to it were the pathologists and older clinicians.
And I'm an old pathologist. That comes double.
So Eva, let's go to you because we've had there's momentum building now. There is some resistance, and even Matt's comments, some urologists will nitpick, I would say, a little bit at that, saying, oh, well, what about this molecular evidence? Does this paper from ages ago, maybe one tiny bit of Gleason 6 metastasized? I'm with you on it, Matt. I totally am. And I think the overwhelming momentum is that we don't think Gleason 6 can metastasize, generally speaking. And that would be okay not to call it Gleason 6 or grade group 1. And we'll find it eventually if it does become grade group 2 or 3. But the momentum's building. And I love this piece in European Urology last month from both of you and Andrew Vickers. And you titled this, Removing the designation of cancer from grade group 1 disease will do more good than harm. And Renu, there were 6 bullet points, weren't there? And we're just going to read out these 6 points because I think it summarizes the clinical argument before we go to Eva about why it's a good thing to do this. Now, we know there's reasons why it's not so simple, but let's run through those 6 reasons.
Yeah, and I mean, I think the main thing for most urologists is the ripple effect that the term cancer has. And I think that's what these points sort of really highlight. So number 1 is the word cancer has a very specific and highly adverse emotional resonance, which is true amongst a lot of our patients.
Yeah,
most of our patients.
And your but your patient Howard Walensky writes very eloquently about that. We'll put some links to his stuff, Scott, as well. That when he was diagnosed with grade group 1 prostate cancer years ago, it was extremely impactful on him emotionally. Yeah.
I mean, once you say to a patient you have prostate cancer, they stop listening, even though the rest of your sentence is, but this is not, this is nothing to worry about, and we don't have to do anything about it. So that's part of that. Number 2 is overtreatment of low-grade prostate cancer remains rife. And this particular problem in the US, isn't it, Matt?
It is. We had some data at AOA this year from the Aqua registry. We're still about 40% treatment for low risk. Interestingly, some further analysis since that presentation, it's a slightly bigger problem in areas with more urology competition. And San Francisco, we're sort of the only show in the city at UCSF from the academic standpoint. So it's easier to keep them on surveillance here. In New York, as a counterexample, they get good advice for surveillance at one center. Right down the street, there's another person doing 1,000 prostatectomies a year who's eager to take out that prostate, or radiate it or what have you. There's, where there's more competition for the patients, we see a greater problem. And there's just huge variation. The one-liner, your likelihood of getting surveillance for low-risk disease ranges from 0% to 100%, depending on which urologist you happen to see with your diagnosis, which is a significant and very persistent problem.
Yeah.
Okay, so there's that. Now, Eva, we're going to come to you. What we're doing is just keeping the momentum going. But these 6 points really outline nicely the clinical perspective, the clinical argument. And then let's come to you. But
yeah, I mean, point 3 just it highlights what we've been talking about. The word cancer causes overtreatment. So it's very hard for men to offer active surveillance when you've called it cancer. Point 4, treatment criteria remains porous, raising the risk of overtreatment.
Yep, that's
Same
true.
sort of thing. A diagnosis of cancer has unavoidable social implications, and a few things have been identified here. So effects on relationships, employment, insurance. We recently saw a patient in MDT who was denied giving a kidney to his son for a transplant because he had Gleason grade group 1 prostate cancer.
This is still a problem.
So that was something that we
Crazy.
Avoidance of the term cancer does not obviate treatment or monitoring, which is true.
So there you go. And it was really nicely elucidated on top of many other things. But in the same issue, I think it is, we have Eva and colleagues from who have a very eminent group of editors involved in the WHO classification, and they argue the rationale for retaining a cancer label. So Eva, yeah, come on, surely it's easy.
Eva's sitting there smiling because she's like, well, we don't call Gleason score 1 prostate cancer anymore. We don't call 2 prostate cancer anymore. Now you don't want to call 3 prostate cancer?
And she's going to make us feel stupid. I get that sense. But can you please just outline the counter argument? And then you're very involved in clinical matters, so I'm sure you have views on these good clinical arguments. But please give us the kind of maybe pure pathology take on why we can't do this.
Eva might have frozen.
No.
Who froze Eva?
Comment first. Not
One sec, Eva.
Somebody is sabotaging Eva's Zoom line.
People, and it's now very well accepted.
I think Matt has sabotaged her.
You have me.
Oh, we've lost
Excellent.
Eva. Okay,
Does that mean the urologists win?
well, is that well, thank you very much for joining us on this episode.
Yeah,
We've figured it out. It's no longer cancer.
We've clearly had
Problem solved. We can all save a bunch of time.
we've had a consensus. Shall we be having a retraction on this argument?
Yeah.
I'm sure she'll rejoin us.
QED.
Yeah, because of goodness me, we had a fantastic, outline from her before we went live on this recording about the rationale for this, and it was very interesting listening to her, Scott, wasn't it?
Yeah, I loved it.
Yeah. Actually, your paper summarizes her paper in 6 points as well. It's just fantastic. And I love point 3. There's this overtreatment is an easily solvable problem. It clearly is not.
Yeah, because we've been trying, Matt. I mean, you think it's an easily solvable problem, but it's the variation's always going to be there, isn't it? And I think once the label is there, as you say, you may be in one institution where you've been told, look, this is, and Scott often tweets about the language he uses, actually, this really reassuring language. And then the person walks out the door, and then his loved one or his buddy says, what, they're not going to treat you?
Can you hear me again?
Oh, we've got Eva back. Yeah, fantastic.
Yes.
Thank you, Eva. Back over to you.
So at the very moment,
No.
you see comment.
Oh, sorry, Eva. You're just breaking up. It's not a good connection.
Sorry.
Such a shame. And she's turned off her video, but we're still struggling, aren't we?
Yeah.
Apologies to the listeners and viewers. Hopefully we will get Eva back with us. Sorry, Eva. We still are struggling. She's gone again. Not to worry. Hopefully we'll get her back. But so if the patient has been told and reassured by a very good clinician, but then they chat to their buddy or their loved one, and they're not going to treat your cancer. Did you not remember Jimmy died of prostate cancer last year? And then if you go for another opinion, you'll find someone who's going to offer you treatment. Isn't that part of the issue? Is that part of the reason why you see it in areas with more competition, Matt? Is that part of the reason why we need to sort of really consider the harm of the cancer label?
Well, absolutely. I mean, I hope she does get back on, because Eva did have a very eloquent argument before we started recording about the pathologic characteristics of what we are trying to delabel as cancer. I mean, there's no question it loses its basal cell membrane. No question it invades stroma. To a pathologist, it has a lot of the characteristics locally of carcinoma. But I think, I was an English major as an undergrad, and with that hat on, the term cancer predates modern pathology by millennia. It literally goes to the time of Hippocrates, and that resonance with the public, I think, is not going away anytime soon. The word has implications and has a certain connotation that has nothing to do with the way it looks under the microscope. And I think, these days we're understanding more and more about these different lesions at the molecular level and the clinical level that goes beyond the histologic appearance. So, in terms of what we should be calling cancer, this is a debate that goes beyond prostate. Like I said before, it's been raised in breast cancer, in the thyroid world. There are certain lesions that have been declassified, and part of the current conversation, I think, is through conversations Scott has had with some of the pathologists involved in the thyroid declassification argument. So, what we call cancer, I think we really need to think about what that word means and how we define it. And something that looks like a duck but doesn't necessarily quack or walk or talk like one, I'm not sure that we should call, in fact, a duck.
Can you hear me now?
Yes.
Much better.
Take your opportunity, Eva.
Okay. I hope I can remain with you. So briefly, I think this is a problem of conversation with the patient first, because in Europe, really everybody, if you suggest Gleason grade group 1, they accept active surveillance. This is not a major issue, or most of them. Second, for us, of course, I agree that we have morphologic changes, molecular changes we do not see under the microscope, of course not. But the diagnosis is still made with a microscope, and our criteria for cancer are loss of basal cells. And we have in Gleason grade 3 loss of basal cells. Even in Gleason grade 2, we have loss of basal cells. So both are cancers. And even if we agree that this is not a very aggressive cancer, it is nevertheless, from a morphologic point of view, it is cancer. And you have these kind of glands which are sometimes not very regular. It can be extremely exhaustive, come as a tumor. You might have more than half of the gland filled out with this cancer. You have, according to several studies, between 0.3 to 6% of T3A tumors, which means extraprostatic extension, even if it's only 3. And for me, it's a big issue is the history with the biopsy, because as long as you just have a biopsy, you just have a part of the sample, you do not have the whole sample. And of course, we can treat everybody with Gleason grade 6, score 6, say, well, now we have the whole sample and it is 6 and nobody will die. This is wonderful. But as long as you're based on biopsies, you cannot say that this is just 6. Therefore, active surveillance is something which is very good. And as soon as we have an increased Gleason score on the next biopsy, it's very good to go towards another treatment or more aggressive treatment or whatever. Afterwards, we can discuss about the different active surveillance issues and samples. But as Jonathan Epstein said, also, would you call, for example, a BRCA mutated person with Gleason score 6 not cancer? I would, yeah, I know you would, but I wouldn't. Or a person, I don't know, who has a huge MRI lesion and it's just, okay, it's just 6. Are you sure there's nothing else in there? I would not be so sure, I'm a pathologist. I just believe what I see on my slides under the microscope. So I would be extremely careful. And you have to start somewhere with the cancer. We don't talk about Gleason grade 2 anymore. So, but 3 is really cancer. I'm sorry, you have the changes, you have the molecular changes, you have the morphologic changes, and I really think we should remain and call this cancer. Afterwards, it's up to you clinicians to say, well, this is a cancer, but it's not a very, very big issue, but it's more a problem of explanation to the patients, in my opinion, especially to the Americans. But the French people have been very reluctant to active surveillance too, and in the end, we got there. So.
Yeah.
So I think we all accept that, and I know Scott accepts that. So, and this is almost like the classic Eva telling us, well, you're entitled to your own opinions, but not to your own facts. And here we go. This is actually cancer, and it's up to you folk, the clinical community, to create a way of describing this entity such that it doesn't get treated like a cancer. But we're not actually changing the facts that it is a cancer. What do you think? What do you think?
Yeah, and we have comparisons within urology, within GU oncology as well. There are those pun lumps or urothelial neoplasia of low malignant potential that we no longer call bladder cancer. There are, tumours in the kidney that are benign that we don't call cancer, such as oncocytoma, which also, like you've mentioned in the past, Eva, do have the histological characteristics of invading stroma, like Gleason 6 prostate cancer. So what makes them different?
The destroyed, but well, the pendulums, the pendulums, if you have a resection of a pendulum, you have the whole pendulum. So you have the sample, you do not have just a biopsy. This is a very big difference between a prostate biopsy, where you just have a very, very small amount of the prostate gland, and the pendulum where you have the whole tumor under the microscope. So you cannot really compare that. Well, normally they always cited these tumors like the basal cell carcinoma of the skin and so on, and the follicular from the thyroid, which do not metastasize. But for me, cancer does not mean that it's really something which has to metastasize at 100%, because there are very many small cancers which do not metastasize. And luckily, they're small and they're low grade, and we can treat them and we can heal the patients. So I think this is something also which should be kept in mind, that, of course, cancers sometimes do not spread, and sometimes they're very small and they're low grade, and we can heal them, and people are very happy about that.
So Scott, this is not a new information. You're very, very used to this argument back from the pathologists. And so what is the solution? Are you going to give up on the idea that we are going to be able to drop the term cancer? Because I know one of your other focus is trying to create a syndrome or a name that we can more strongly attached to the diagnosis that might help mitigate it. That almost pushes the cancer thing deep down into the subtext so far down. Or do you still feel that the momentum will be such that we can get somehow the cancer label dropped? Because I personally feel we're going to struggle with that, even with really, really clinically astute people, like many of these GU pathologists like Eva are. They'll say, yeah, but it's still cancer. It's not a pendulum. It's not an oncocytoma. It's cancer.
Yeah, I'm hopeful and confident and admittedly biased that we'll get there, because I think it's the right thing to do. But what Eva said is absolutely correct. In 2022, by current histologic criteria, it meets the definition of cancer, but that is a histologic and subsequently a social construct of where we draw the line of what we call cancer or not. And it has massive implications for public health, and not in a good way. And if you just take a step back on a macro level and look at any dictionary definition of benign versus malignant, basically benign versus cancer, cancer is something that can, replicate endlessly, spread, cause pain, cause death. Gleason 6 does not meet that definition. Genetically, molecularly, there are precancerous lesions that share characteristics with grade group 1, grade group 2, grade group 3. We don't call those cancer. There's a lot of men walking around with grade group 2 or higher. We screen them. They've had a previously negative biopsy. They may have grade group 1. And I guess that, there's so many different elements that I could, push the conversation. But I was at a conference recently and asked a large room of people, mostly men, but also women. And I said, if you have a prostate or you love someone that has a prostate, raise your hand if you'd want to know right now whether you have grade group 1 in your prostate. Not a single person raised their hand. And we know for men over the age of 50, roughly 30 to 50% of them are walking around with prostate cancer. And anyone who knows anything about clinical prostate cancer probably doesn't want to know about it.
And I think that's the key, isn't it?
Most people don't want to know about their cancer. I'm sorry.
But that is actually one of the biggest points, because we are doing so much to try and not know about.
Yeah, I've got my hand up. The 51-year-old here, who's
we don't want to know about it.
Fully don't intend dying of prostate cancer, touch wood. But I have no interest in knowing whether I've got grade group 1 prostate cancer.
Absolutely, and we're even trying to stop patients from getting to the point of a biopsy if they don't have anything more than grade group 1 in their prostate. So this would really solve a lot of those problems.
Because Eva, we only think they want to know about it if we worry them enough to think you need to know about it. But if we pivot away from that, Matt, and say you don't need to know about this, and that's part of the beauty of using MR up front is Precision showed how much you drop the grade group 1 diagnosis rate from like 27% down to 9%. We don't need to find those 20%, or probably nearly any of them really. So
that's sort of exactly the point.
Sorry.
Go ahead, Eva.
No, it's just, I would be really for example, I have 12 biopsies, and let's say there are 2 biopsies with 1 millimeter Gleason grade 3+3, wonderful. And of course, this is ideal patient for active surveillance. But if I have a patient, let's say, and I see patients like this, with 10 biopsies out of 12, and they have huge Gleason score 6 on their biopsies and on 10 biopsies, I would be a little bit more worried whether there's something hiding right behind. And of course, I would do at the beginning probably something, and I'm not, I'm just a pathologist, but in these cases, I'm pretty sure that there's something behind from a morphological or biological view, which is much more dangerous. And it's the same Gleason 3+3, so I think it's, you cannot stop calling it cancer just because it's small, because it doesn't spread and so on and so on. I think it's really the wrong way. And you will lose patients in active surveillance because they will say, well, you know, guys, I don't have really cancer, so I don't care about it. And he will go to his garden, I don't know, in the Rocky Mountains and never come back again.
That's a reasonable thought, but I don't think that would happen if.
Look, it's a really important point.
Yeah.
This is a really important point, because nobody is suggesting that we call this normal. And frankly, I think most of us that are on the pro side of this would say active surveillance should look exactly the same with a change in nomenclature as it does today. It should be tailored based on the specific criteria. We need to follow somebody a lot more closely who's got 10 cores of 3-3 than somebody who's got 2 cores of 3-3, but they need to be followed. Conversely, it is perfectly reasonable to do a mastectomy on a woman with extensive DCIS, even though that's not a cancer. It's perfectly acceptable to do bilateral mastectomy on women with no cancer just based on genetics. So there are plenty of specific instances where, you know, proactive radical therapy would be appropriate for something less than cancer, but the bar should be much higher to justify that sort of treatment than it is today. And I want to step back the conversation even one more level at the public health level, which is, you know, I fully admit that the number of men we might lose if we do this because they don't surveil, because they don't take it seriously, is probably above 0, but it's not much above 0. And in the meantime, you know, you think about the tens of thousands of hundreds of thousands of men around the world who die every year because they don't even get a PSA screening test, because their primary care doc doesn't offer it to them, because they are still so concerned about overtreatment and overdiagnosis in the urology community. That to me is the one of the most powerful arguments here. You know, in the US, we've gone from this D recommendation of don't screen anybody ever in 2012 to now a C, based in large part on rising rates of active surveillance. We now have this C recommendation, meaning, well, you can talk about PSA screening, you should have shared decision-making, but we still don't really recommend it. You know, and the reality is only about 30% of men in their 50s get PSA tested in the US. And if we want to convince our colleagues in primary care to take us seriously, that we will not overdiagnose or overtreat this disease, you know, this change would shift the balance of benefits to harms so strongly in favor of screening. My expectation is we would find thousands more aggressive cancers that really need treatment, more than making up for by orders of hundreds or thousands, making up for whatever small numbers we may lose, if any, through less intensive surveillance. So that, you know, this public health argument to me really is you know, the one that keeps us going here, I think.
But may I just ask you a question, because you talked about BRCA mutated women who have mastectomies. So you have a BRCA mutated man, you know, he has a risk for prostate cancer. He doesn't have a prostate cancer. Will you take his prostate out?
I would not, but I have colleagues around the world. So the Martini Clinic in Germany has done at least a half a dozen of these. I believe in Canada, there's a small series of these. To me, you know, what we have, the breast cancer does not have as a field, is the PSA test. And you show me a guy with a BRCA mutation and a PSA of 0.4, and I'm going to say, you're great. We need to keep a close eye on this, but we don't need to do anything right now. You know, you show me a guy at 48 with a BRCA mutation and a PSA of 1.4, we are definitely going down the path of imaging, potentially secondary biomarkers, potentially biopsy. And, you know, that is somebody who I would think about treatment. Because remember, with surveillance, the question is not treat yes or no forever. It's, do we need to treat now versus can we wait? And the guy with a BRCA mutation and a Gleason 3-3 diagnosis, you know, that man needs treatment at some point. Does it have to be today? Not necessarily. And, you know,
I think Eva brings up a really good point. And I think Most thoughtful urologists around the world think about it this way. You take every piece of information you have available on a man, and you try to estimate the likelihood that they have pattern 4 or grade group 2 or higher in their prostate. And that's in the screening setting. What's their PSA? What's their DRE? What's their family history? What's their germline status? And even in the surveillance setting. I mean, we used to do this very rigorous annual biopsy for surveillance. We now know, and I'm sure the 4 clinicians on the call, when you're doing surveillance, there's guys I keep a close eye on, and there's guys I really dial it back. And it's all about what is their risk of having pattern 4 or higher. And we've got a dozen different things that go into that stew to estimate their likelihood of having kind of real consequential disease.
And it's the same for the BRCA2 one, Eva, and the super high volume, the MR lesion, etc. We're not going to, we're going to follow those patients. If we do a biopsy and it's a thing that it used to be called Gleason 6 in the old days, but now it's not. It's a different thingy. It's not cancer. We are not going to just discharge the patient, right? So as Scott says, we have a stew where we're going to follow them. But for every one of them, like there's 20 or 30 men with one core of grade group 6, and it's a massive impact on their lives. Like they are harmed by this. And if you listen to patients, as I've mentioned, like Howard Walensky, they write very eloquently about how they have been harmed by this financial toxicity, stress, marriage, all sorts of things, by this completely unnecessary label that gets attached to them. So I think there will be some trust that we're not going to disadvantage the other extreme of patients who perhaps could be underdiagnosed with a subsequently clinically significant cancer, but it's still a big problem, labeling all these people as cancer. So I think that's the great argument. And I feel the momentum, Renew, is going towards the pathologists and the clinicians actually going to meet in the middle somewhere on this. And I don't feel we'll be sitting here in 5 years having not moved on. I get the feeling that the momentum that Scott and others have built will lead to some sort of resolution of the situation.
I hope so. I mean, because
we need to help patients. We need to stop.
Absolutely,
There's a lot of harm.
We see the harm. It's a very palpable thing.
Scott, my cheery thing. What do you think? What is the momentum? Where is are we going to meet up in Bali or Egypt or wherever like world leaders meet to come to resolution?
We're going to start in San Francisco.
We start in San Francisco, or maybe it'll be on Zoom. We don't have funding, but what do you think? I mean, you've built a lot of momentum. This is part of it today. We want to.
But Scott, you've also mentioned this. There are a lot of pathologists in favour of the reclassification as well, aren't there? Tell us a little bit about that before we finish up.
Yeah, I'm happy to report that there's 4 very prominent GU pathologists with leadership positions in pathologic organizations, GU pathology organizations, that have a paper coming out soon arguing on our side of it. And so things evolve over time, and people can change their minds, and some people never change their mind. And to what Matt mentioned earlier, I think the time is right, the momentum is there, and we will continue the conversation, and we'll see where it plays out.
Eva, what do you think? Can you see a resolution? How can we help patients? That's the momentum. You're talking to people who make our living out of doing surgery and stuff like that, but we want to not find these patients. And for me, as a full-time prostate cancer specialist, it means I will have less work. But I think it's important to do it because I think we have to help these patients, the ones who are being harmed by being called cancer.
Yeah, but you will not have less work because anyway, they have Gleason score 6. So if you put them in active surveillance, you will have some work too. You don't have to do surgery anyway.
I think if it's one core of that's what we're saying. There's a line. If that's a one core, you've got Gleason 6, and we've biopsied them because of the PIRADS 3 lesion or the high PSA. But if it doesn't say cancer on the thing, they're not going to be on active surveillance. They're discharged back to the GP with, as usual, a recommendation to keep an eye on this PSA because as our patient gets older, he is more likely to develop prostate cancer, and but he doesn't have cancer now. And then you drop out of the unnecessary biopsies and morbidity and so on because we'll have said doesn't meet the threshold. Whereas if that lesion, whatever it's going to be called, is high volume, or there's another clinical, I'll keep an eye on you myself. Perhaps we'll repeat your MRI in a couple of years or do genomic testing.
Yeah, but PIRADS 3 shouldn't maybe be a biopsy. That's another history.
Oh,
I wouldn't advise that, but that's another history.
That's again a different topic. But I think we'll get there. I think that it's got such prominence now Scott, thanks to your writing and others and big journals like European Urology interested, really top pathologists like Eva and colleagues coming to the table, I feel there'll be a way forward. Maybe it needs to be around the fringes.
In fact, nowadays when we speak to patients who have grade group 1 disease, especially very low risk prostate cancer, we basically say, there's an argument to not even call this cancer. Yeah. And you see their faces kind of just relax a little bit.
Yeah. And Scott, finally, any tips? You've written very nicely about the way you speak to patients about this diagnosis. So this is not going to be fixed today. So as we go into the clinic today or this week, and you've got a patient newly diagnosed with relatively low volume, like straightforward grade group 1 prostate cancer, what are your tips for communication strategies with those patients while we wait for a resolution?
It's amazing how things have evolved over time. Me, you, and Matt are basically the same age. I can tell you, I was the first person in Chicago about 14, 15 years ago that would put people on surveillance. And they were really long discussions where I'd have to talk about every option. It'd go 30, 40 minutes. Not everyone would do it. It's pretty straightforward now. I mean, 95% of people that have Gleason 6, I describe it as, you have a small amount of the wimpiest form of prostate cancer we know of. It's incapable of causing you any symptoms or problems. I recommend surveillance. Here's the wonderful long-term data. I'll see you back in 6 months.
Wimpy cancer.
I like it.
Would that fit in some sort of classification, Eva? We said cancer, but a bit wimpy. That might be the solution. I love it.
No, I'm sorry. No, for me, it's really cancer. And, I will not change my mind immediately.
I hear you. Well, look, that's fantastic.
I'm still on the cancer side.
I hear you. And Matt, any closing comments from you, Matt?
No, I would just say that we really are trying to keep this conversation going. And Scott and I have been working actively together with Adam Keibel and Ali Berlin as radiation oncologists to try to get a true multidisciplinary symposium together, parallel with the GU ASCO meeting next year.
Fantastic.
We're going to hold that at UCSF, close to where the meeting is going to be. And this will be truly an interdisciplinary panel with voices on both sides of this argument. So hopefully we'll be able to drive some further progress and start getting us toward a consensus.
Fantastic.
So I do think the momentum is here this time around, which is actually pretty exciting.
Terrific. And I think you've kindly invited me to that. I'm definitely coming along. I'm really enthused now.
There it is, our latest podcast on wimpy cancer.
Yeah, I love it. Eva, Scott, Matt, thank you so much for joining us. It's been a great pleasure as ever. I've learned a lot from this, and we'll try and keep the momentum up. I think it's a really important discussion to have, and we look forward to it. Take care.
Thank you. It was a pleasure.